the immediate past chairman of Medical Advisory Committee. He has to his credit a numerous publications, and he has presented his work in different parts of the world. He's a peer review author for some well-respected international journals. And the title of his talk today is the underuse and misuse of newer anti-diabetic medication which established positive cardiovascular outcome. Okay, Dr. Syed Raza, if you are ready, please start. And thank you for being here today.
Yeah, thank you very much. First of all, can you hear me?
Yes, we can hear you.
Okay, so thank you very much for the very kind introduction, and thank you very much for inviting me here. And a very good morning to all audience. It is close to 10 o'clock here in the UK. I'm aware people are joining from different time zones, so I'm not sure whether it will be afternoon at some places or evening. Yeah. But anyways, good morning from me from the UK. So in the next 25 or 30 minutes, I'm going to talk about as to how we choose treatments for our patients. And then I'm going to discuss very briefly providing the evidence for newer anti-diabetic medications. And I will be presenting some of the cardiovascular trials that have been done with some anti-diabetic medications. I'm also going to discuss the limitations on use and misuse of these anti-diabetic medications. And finally, I will finish with the ways to improve the prescription writing and treatment. Now, the question is, how do we choose treatment and prescription for our patients? Now, as healthcare physicians, as healthcare professionals, we practice evidence-based medicines, and we have provided some guidelines. If this could be national guidelines or international guidelines that we follow, and then we prescribe or provide treatment for our patients. Occasionally, we also depend on our personal experience of use of medications and treatment, but we must not forget that it is the patient who is the end user. At the end of the day, these are the patients who will be taking these medicines, the prescription. And mind you, we have got to take that into account. We have to have a discussion with the patient as to what their preference will be for the prescription or the medication we provide. All the medication do not come cheap. There may be a cost issue, there may be a side effect issue, there may be intolerance issue of the medications and prescriptions. So we must bear that in mind. And only then we should prescribe medications to the patients. Occasionally we depend or we rely on our gut feeling. So we feel that this medicine will work for this particular medical disease or medical problem, and we use those medications. And rarely some of the physicians also are hunting in the darkness. They may give a cocktail of medications, whether they would work, whether they'll not work, or they'll cause side effects, that is up to their imagination. So this is, I would certainly say, is not a good practice where we hunt in the darkness. Certainly, this way may lead to side effects, they may lead to complications, and may also waste a lot of resources when we provide treatment or prescriptions to our patients. So what we rely on, what we depend on is on the evidence-based medicine. We follow evidence-based medicine because there is an evidence, or there's ample of evidence through clinical trials. And these trials may be randomized clinical trials or few smaller trials. But at the end of the day, we practice medicine because we see that there is evidence for a particular group of medicines or drugs. So I've given you some examples here. These are mainly the medicines that are used in cardiovascular medicine, antiplatelet drugs. Like we all know, there is clopidogrel, there's ticagrelor, there's prasugrel, and there are a few more antiplatelet drugs. And we have got ample evidence for writing these medicines or prescribing these medicines. Likewise, statins. Statins, as you all know, is these are medications that help to reduce cholesterol. But we also know that they also help to help you to live longer, to prevent heart attacks, to prevent strokes. So statins have been proven to be beneficial by not one but thousands of trials, and these are large trials, randomized controlled trials, and meta-analysis have proven beyond doubt that statins are indeed, they provide benefit for the patients. The other medications are beta blocker, ACE inhibitors, MRAs. We all know that there are trials, they are very good trials, and these are all evidence-based medicines that we use in cardiovascular medicine. ARNIs, angiotensin receptor blocker, neprilysin inhibitor, and it is a combination of valsartan and sacubitril. And this has been in practice for last 4 to 5 years. And this has been a game changer in heart failure. Likewise, GLP-1 agonists and SGLT2 inhibitors have been a game changer in diabetes mellitus. So today I'm going to focus mainly on these two medications, GLP-1 agonists and GLP-2 inhibitors, and these are the anti-diabetic medications. These are the newer anti-diabetic medications that have been a game changer. I have briefly mentioned about the misuse, and in particular when I'm talking about two inhibitors. Now, some of these medications are contraindicated. SGLT2 inhibitors in particular, they are contraindicated if patients have got severe renal impairment where eGFR is less than 15 ml per liter. If the patients are severely dehydrated, if they have got current urinary tract infection, if they're hypotensive, likewise, if there is pancreatic disease or there is high risk of diabetic ketoacidosis, both the above mentioned medications are contraindicated. Medications are being used or misused in type 1 diabetes mellitus. FDA has not given any green signal for the use of these medications. They are being used as off-label. So these medicines, in a way, are being misused. They are also being used in patients who have got low body mass index, which means these patients are very lean and thin. They have got hardly any muscle on their bones. And these medicines should be avoided in these kind of patients. And some of you may know that GLP-1 agonists have been used or are being used for patients to lose weight. But sometimes these are being used in patients who are non-diabetic. FDA says that the patients who are overweight, who have got high BMI, particularly more than 30, and if they are diabetic, then these medicines can be used. But sometimes these patients are not diabetic, and just to adopt a shortcut method, the patients either demand or the physician, they write these medicines just for weight loss alone. So what are the reasons for poor usage of newer anti-diabetic medications? Some of the things I've listed here, this is mainly due to lack of awareness of current guidelines based on evidence of cardiovascular and renal benefit from trials. So some physicians, they are not aware of the current guidelines that are based on not one, but number of trials that have been done on these medications. And they do not know what cardiovascular or renal benefits that have been shown from these trials. Sometimes there is inertia to start a treatment. They're not ready to start treatment because they think that these medicines are new. They do not develop that confidence to write or prescribe these medicines in the first place. There may be some local restrictions and supply. Now, this may be mainly because of the cost factor, but there may be other reasons. There may be local reasons why these medicines do not gain entry to their pharmacy or formulary. There's lack of multidisciplinary team approach to a patient. Now, as you all know, these medicines which I have mentioned, they are also being used by cardiologists, by nephrologists, by general physicians, and diabetologists, of course. But there should be a teamwork. There should be MDT, multidisciplinary teamwork, where each of them, they talk to each other, they feel that where the medicines will be useful in their subspecialty, and then only these medicines will be prescribed for a patient. Affordability, as I said, is a factor because these medicines, mind you, are not cheap. They are quite costly medicines. But finally, it is also important to educate our patients. If you do not educate the person you are giving these medicines, then certainly that person will not have much idea, much knowledge about these medicines. The patient will not be confident enough to use that medicine. And this is going to impact on the compliance as to how these medicines will be used. And certainly it will have an effect on the medication adherence. Now, coming to diabetes and cardiovascular mortality, this graph shows that if you have diabetes, then certainly the mortality is much higher. And along with diabetes, if somebody has got 1, 2, or 3 risk factors, then there is exponential rise in the cardiovascular mortality in diabetes in the patients who have got diabetes compared to patients who do not have diabetes. Now, we all know by now that if somebody has got diabetes, this alone increases the risk of heart disease by 2 to 3 times. And it also increases mortality by 60%. So if somebody has got diabetes, then over the number of years, the risk of death or cardiovascular death is almost 60%. Now, some of the benefits of newer anti-diabetic medications, namely the SGLT2 inhibitors and GLP-1 agonists, have been mentioned, and there are metabolic effects and there are non-metabolic effects. I'm not going to go through the whole list, but metabolic effects, certainly it is the glucose that we are interested in. We are also interested in to reduce the triglycerides. And mind you, these medicines, they also help you to lose weight, reduce the visceral fat, and so on. In addition, if you see the non-metabolic effects, it decreases the blood pressure. It also reduces arterial stiffness, decreases albuminuria, and improves renal function. So certainly it has got benefits on the kidneys as well. Now I'll take you back to 2008 when there was a problem, excuse me, of some glucose lowering drugs, and rosiglitazone, as some of you may have heard, it came into limelight. It was a talk in the media that patients were having complications, and that was also increasing the cardiovascular mortality in patients who were taking the rosiglitazone, which is one of the anti-diabetic medications which is not seen much in the market now. And soon after that, the FDA made mandatory that there should be any new medication that is launched in the market, anti-diabetic medications, they must show a cardiovascular safety. If not, they should show that they are cardiovascular neutral, meaning thereby, if they do not show any benefit, they should also not show any harm related to that medication. So while we are talking about the cardiovascular risk reduction, as you all see on the left-hand side, these are only metformin has got a questionable benefit, but pioglitazone is again one of the glitazones, GLP-1 receptor agonists, which I'm talking about now, and the SGLT2 inhibitors. These are the medicines that have shown to decrease the cardiovascular risk. Now, there have been several trials that have been done on the GLP-1 agonists as well as on the SGLT2 inhibitors. And this is the timeline. You can see the number of studies that have been done right from 2013 up to 2020. Now, I'm not going to ask you to read this busy slide, but all it shows, it gives you a summary of all the medications and all the trials that have been done with them and how they have reduced the major adverse cardiovascular event, how they have reduced cardiovascular death, and how they have reduced hospitalization for heart failure. Now, I'm very briefly going to touch upon a few trials that have been done with these medications. Now, first and foremost, I'm going to discuss the CANVAS trial, which was done with Canagliflozin, which is one of the SGLT2 inhibitors. Now, how these patients were chosen, 40% of the patients that were studied who had diabetes and they had 1 or 2 risk factors for cardiovascular disease. But majority of them, at least 2/3 of these patients, they were diabetic and they also had established cardiovascular disease, meaning thereby either they had a heart attack they were already suffering from angina, they had PCI, or they undergone CABG, or they had suffered stroke or peripheral vascular disease. So Canvas was actually clubbed with Canvas R. Canvas R is the renal arm of this trial. And once they were clubbed together, this was called the Integrated Canvas Program that included almost 10,000 patients. And then again, they were randomized either to receive Canagliflozin or placebo. And then they were followed up for a good number of years. And straight to the result, as you can see here, the Canagliflozin. Now, this is the primary MACE outcome that they were looking at. And MACE is the composite of three factors: the cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And as you can see here, that the Canagliflozin had a superiority, or had shown a superiority which is statistically significant over use of placebo. That means Canagliflozin did show that it reduced cardiovascular death, it reduced non-fatal MI, and also reduced non-fatal stroke as compared to placebo. Now, moving on to empagliflozin, this is the EMPA-REG, is the most famous trial that has been done for looking at the cardiovascular outcome using this SGLT2 inhibitor, empagliflozin. Empagliflozin, this screened about 11,500 patients, randomized and treated about 7,000 patients. And these were all adults type 2 diabetes mellitus. And the beauty of this trial is that 95% or 99% of these patients already had established cardiovascular disease. So these patients were diabetic, and they also had established cardiovascular disease, 99% of them. Now, these patients were divided into three arms: first to receive placebo, second arm to receive empagliflozin in a lower dose, 10 milligrams, and third arm was empagliflozin that received 25 milligrams of empagliflozin. Now, the primary outcome here again was 3-point MACE. That was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. As you can see here on the screen, again, 3-point MACE favored empagliflozin in comparison to MACE. Cardiovascular death was significantly reduced in favor of empagliflozin. Non-fatal MI was again reduced in favor of empagliflozin. Only it is in non-fatal stroke that did not show any benefit in favor of empagliflozin. Now, this is something we can discuss when it comes to a discussion why there was increased mortality or stroke, non-fatal stroke that was seen with empagliflozin in this trial. Now, coming to the third and the biggest trial that has been done with SGLT2 inhibitor is the DECLARE TIMI58 cardiovascular trial. And this used about 17,000 patients, but mainly 2/3 of these patients had diabetes but had cardiovascular risk factors, and only a small proportion, almost 1/3 of the patient, had risk factors for cardiovascular disease. So they did not have, majority did not have established heart attack or stroke, but they had risk factors. Now, primary outcome again was cardiovascular death, heart failure, and 3-point MACE. Now, as you can see here, it favored MACE as well as cardiovascular disease, and heart failure was in favor of dapagliflozin compared to placebo. And when we look at the renal composite and heart failure, once again, it favored the dapagliflozin as compared to placebo. So it is very much clear that whether it is heart failure, whether it is renal failure or end-stage renal disease, which is renal composite endpoint, that includes a lot of things. That includes end-stage renal disease. It also includes renal transplant, patients going to receive dialysis, and so on. So everything was in favor of dapagliflozin. Now, the last trial I'll need to discuss here is the VERTIS CV trial. And this was again done using another SGLT2 inhibitor, which is ertugliflozin. And once again, it's not a surprise. It showed a non-inferiority in favor of ertugliflozin compared to placebo, where the p-value was less than 0.001. And it also showed, in fact, it did not show a superiority, but it did show a non-inferiority, which again is okay as far as the drug is concerned to be launched in the market. Now, coming to the SGLT1 agonists or receptor agonists, Again, these are the drugs that have been mentioned: lixisenatide, exenatide, liraglutide, semaglutide, and so on. And all of these medicines, as you can see, are pretty much safe to be used in type 2 diabetes mellitus. But the most important trial that stood out from all the other trials is the LEADER trial that was used, that has shown a significant cardiovascular benefit or cardiovascular outcome in type 2 diabetes mellitus. And this was done using liraglutide, one of the GLP-1 agonists. And study design was, as you can see here on the screen, that used liraglutide 0.6 to 1.8 milligram in the increment dose, and plus they continued the standard of care. And what they were looking at, not only the effect of the drug, but also the safety follow-up was also included. And again, once again, you see that liraglutide did improve or reduce the cardiovascular event compared to placebo, with a hazard ratio of 0.87 and 95% confidence interval. So the conclusion that was drawn was that there was no increased risk of major adverse cardiovascular event, but as a matter of fact, it improved the cardiovascular outcome in favor of liraglutide. The other GLP-1 agonists that has been studied is semaglutide very recently, and I'm not going to go in a lot of details, but as you can see here, it reduced non-fatal myocardial infarction, non-fatal stroke, and also death from cardiovascular causes. All of them were in favor of semaglutide compared to placebo. And then there was another drug that was used is GLP-1 agonist is dulaglutide. And this was in the REWIND trial. And the primary outcome, a major cardiovascular event, was once again in favor of dulaglutide compared to placebo. Now, when it comes to choosing the anti-diabetic medications, we must keep in mind that once we have educated the patients on the lifestyle, once we have started metformin, which of course still is the first line treatment for diabetes patients, and then the question is, what do we do next? So we must keep in mind whether these patients have got underlying cardiovascular disease or chronic kidney disease, or they do not have cardiovascular disease or chronic kidney disease. So if they have a cardiovascular disease or chronic kidney disease, then obviously you're going to follow on your left-hand panel these, whether they have heart failure, chronic kidney disease, or they have atherosclerotic cardiovascular disease. And then you're going to choose the medication that will be right for these patients. So finally, I'll just draw your attention as to what we need to do as physicians when we prescribe medicines for our patients, and in particular our diabetic patients. We must try to educate ourselves. We must update ourselves of the current practice, of the current guidelines that are there. We must not only update ourselves, but we must bring those guidelines into practice. We must be keen to prescribe as a non-diabetologist. No, I'm not a diabetologist, I'm a cardiologist, but I do prescribe these medicines because I have gained confidence from whatever I have studied, whatever I have come to know through lectures, through seminars, from my own readings, through my own research, that these medications are useful. These medicines, they reduce cardiovascular event, and I'm quite confident to prescribe these medicines and also modify these doses if they have been prescribed by my colleague. We must understand the role of the pharmacy and the therapeutic committee. We must encourage them, and we must also educate them, make them aware of these medicines so that they are easily included and they are adopted in the pharmacy or in the hospital formulary. These medicines, as I mentioned in the beginning, these are costly medicines, they are not cheap medicines. There must be a means from the government or the hospital management that these medicines should be subsidized. The price of these medicines must be reduced so that these medicines are affordable, even those who think that these medicines are out of their reach and they cannot bear the expenses of these costly medicines. And finally, it is important to educate our patients. So this is something that is very close to my heart, and also bring this topic or issue that we must educate our patients when we are prescribing any new medicine to them. because at the end of the day, it is the patients who are going to use these medicines. And if they do not understand the medicines, then you know what is going to happen. They will walk out of the clinic and their medicines may be thrown in the dustbin the next moment. So therefore, I just want to emphasize to all the listeners and the attendees here that it is essential that we educate our patients. We must take time, few minutes, even it may be 2 minutes, 3 minutes of your clinic time. We must educate our patient about the medicine that we are prescribing so that they understand why it is being given to them. They must understand what is the benefit. And of course, we must allow them ample opportunity to ask questions about the side effects and complications, because this is something that they fear, that these medicines are new. They do not get confident. They think that it may give them side effects. It may give them complications. But when a patient starts to talk to me about the side effects and complications, I say, okay, hello, just wait there. Let's not talk about the side effects first. First of all, we are not, or I'm not giving you these medicines for side effects. I'm giving you these medicines for benefit. So these medicines have been developed for your benefit, and they're not have been developed to give you side effects. Yes, they have side effects, but these side effects are very, very, very rare. And if they do get side effects, it's not the end of the world. We can always reduce the dose of the medicine, or we can stop these medicines. So this kind of discussion is important when we are talking to our patients. So with that, I would like to thank you for your patient listening. And if there's any question from your end, then I'm keen to take.
Thank you so much, Dr. Syed Raza.